So I'm Dr. Patsy Kelso from the Vermont Department of Health. I'm the state epidemiologist for infectious disease, and I'm going to tell you the story of the Vermont MDRO Prevention Collaborative. Before I get into our story, I wanted to make sure you're aware that preventing healthcare-associated infections is one of the CDC's top 6 winnable battles. It's something that they feel public health can make a difference with preventing these infections. And so this slide is a CDC slide, and I've put that arrow there to show you that HAIs, healthcare-associated infections, are on CDC's top 6 priorities. And this is another CDC slide. Dr. Tom Frieden, the head of CDC, has set some specific goals around HAIs for 2011, and our Vermont MDRO Prevention Collaborative is hitting almost all of these very specifically. So we're integrating HAIs into state capacity, so I'll talk a little bit about that, how we have a position now at the Health Department dedicated to preventing HAIs. We're working with NHSN, the National Healthcare Safety Network, to report data, and we have gotten long-term care facilities in Vermont to enroll in NHSN. We're transmitting that data electronically to CDC, and we're also specifically focusing on C. difficile and other multidrug-resistant organisms. So we're really touching a lot of the CDC's priorities with this project. In 2009, the American Recovery and Reinvestment Act provided funding to support state health department capacity in preventing HAIs. So we heard about these funds being available, and the health department worked very closely with the Vermont Program for Quality in Healthcare, VPQHC, and Banking, Insurance, Securities, and Healthcare Administration, BISHCA. The 3 agencies worked closely together to develop our ERA funding application. And I think Vermont was in a really good position to receive these funds because we had been the first state to publicly report hospital infection rates using CDC's NHSN system. And we were the 4th state to report rates specific for hospitals, hospital-specific rates. So we did get funding through the ERA grant, and the funding allowed us to create a new position at the Health Department for an HAI prevention coordinator. We've got that position filled now with someone who's certified in infection control, and she's a great resource for us at the Health Department and for healthcare facilities around the state for questions or concerns about infection control. We also worked with VPQHC and BISHCA to develop our state plan for HAI prevention. And we're currently working on a project to validate the NHSN data that hospitals report to BISHCA for the hospital report cards in Vermont. And then finally, the ERA money helped support the HAI Prevention Collaborative. This is the CDC website showing the homepage for the Recovery Act funds specifically focused on preventing HAIs. So we had an idea in Vermont that any collaborative that we did should include both acute care facilities, hospitals, and long-term care facilities, because patients continually travel back and forth between those types of facilities and into other community or home settings. And so you can't prevent healthcare-associated infections by just focusing on one type of setting like hospitals. And when CDC learned that we were proposing to include long-term care facilities in our prevention collaborative, I got a call from John Jernigan in February of 2010. And he said, that's exactly the way CDC wants to see projects like this move ahead, is by including long-term care facilities. So why don't you focus on MDROs and also report this data electronically to CDC? And so we talked for a while, and with help from CDC through a contract with HUNET to get the electronic data flowing, we developed our MDRO Prevention Collaborative. So a key component of our collaborative is that we've grouped Vermont healthcare facilities into what we call healthcare clusters. And these are hospitals and long-term care facilities that serve the same community, and by working together, they can affect change. So this diagram shows that there's a hospital and then several long-term care facilities within a single healthcare cluster team. So we started thinking about, okay, how do we break Vermont healthcare facilities up into clusters? So first we mapped the hospitals in and near Vermont. And this map shows where they are. They're spread throughout the state. And then we took a look at the long-term care facilities that had skilled nursing components. And again, those were spread around the state. And we thought, well, what's the best way to create a cluster? So our initial thought was, we'll ask facilities who they share patients with most often, and then those facilities will be grouped together in a cluster. And when we asked those questions, we got data that looked like that. And it was really hard to identify how we would separate clusters based on that information. So we decided the simplest thing was to just pick geographically located acute and long-term care facilities so that they were pretty near each other in the state, not at opposite ends, that they share patients in a laboratory. And that's a key part because the ultimate way we're going to measure success of this collaborative is in preventing healthcare-associated MDRO infections. And so we need lab data in order to assess that. So we wanted to include long-term care facilities with the same hospital where they send their clinical specimens so that we could track the data more simply. And those clusters work together as acute and long-term care partners to decide which interventions they want to try and what's best for them. They can also support each other with peer-to-peer learning and support. We found that the hospital infection preventionists have been a great resource for those in long-term care who typically don't have as much expertise in infection prevention. So we threw out a whole bunch of ideas for innovative prevention activities that facilities and clusters could choose to work on to try and prevent MDROs. And I've listed some of them here. They include things like better communication between facilities when patients are transferred, modified or enhanced contact precautions, environmental cleaning, hand hygiene education and observations, antimicrobial stewardship, use of chlorhexidine bathing, and promoting good urinary catheter practices. As I said, the other thing we wanted to achieve with the collaborative is electronic reporting of MDRO clinical lab data into NHSN. And we're working with HUNET, who is individually working with each Vermont hospital with their IT departments and their clinical laboratory and their infection preventionists to pull data out of the lab information system, package it in the proper format, and upload it to NHSN. And so far, we've got 8 hospitals in Vermont who have sent data electronically to NHSN, so we're well on the way there. And we also know that NHSN is developing a new component specifically for long-term care. Some of the questions in the original NHSN Lab ID event module weren't really relevant for long-term care settings. So CDC is developing a new component, and Vermont facilities are already enrolling in NHSN, and so when the long-term care component is ready, we'll be ready to get our long-term care data in there. So one of the core components of our collaborative is that we've had some full-day learning sessions every few months where we brought 2 or 3 people from every healthcare facility together for a full-day learning session where they can hear from subject matter experts. And we've been fortunate to have staff from CDC attend our sessions and provide subject matter expertise. We've provided them with guidance and information and instructions on using NHSN to report the data. And then it's been a great opportunity for them to talk to each other, learn from each other, and hear what each other is working on. So we're working on planning for some upcoming learning sessions. And in the meantime, in between those learning sessions, we do what we call coaching, cluster coaching. So staff from the health department or from VPQHC reach out over telephone to people at each facility in each cluster periodically to find out what they're working on, what their successes are, what their challenges are, and whether the health department or VPQ can be of any help. We also have staff attending some of their cluster meetings. So in between the learning sessions, the clusters are working together on whatever they choose to prevent MDROs. And they periodically have meetings of their clusters locally. And they've invited us, and we've been happy to attend many of those meetings. And we're also providing them help with NHSN enrollment and requesting digital certificates and things like that. So some of the successes we've already achieved still within the first year of this project. There's, I think, much improved communication between acute and long-term care facilities at the time of patient or resident transfer. So there's an inter-facility transfer form that many facilities in Vermont have adopted. Some of them have tweaked it a little bit to meet their own needs, which is great. And anecdotally, we're hearing that there's a lot better information sharing when a patient with an MDRO is transferred from one facility to another. They're also recognizing needs and issues related to environmental services and cleaning of their facilities. They're achieving physician involvement in discussions about use of antimicrobials and use of catheters and things like that. In a lot of clusters, physicians routinely attend the cluster meetings. Some facilities are working on developing guidance for and implementing enhanced standard precautions. They have developed new MDRO patient and family educational materials and developed bulletin boards and things inside their facilities to educate staff and residents and families. Some facilities are doing active selective surveillance for MRSA. They're getting their clusters together as a group and doing cluster-wide or facility-wide trainings on how to use NHSN. They're developing resources to be able to do hand hygiene observations, which is labor-intensive and a challenge. And they're also looking at evidence-based literature as they develop things like urinary tract infection protocols and trying to address antimicrobial stewardship. Some of the things they've identified as challenges so far aren't a huge surprise. There's little control over environmental services, especially in long-term care facilities. The cleaning staff are often provided by a contractor, and so no one at the long-term care facility has direct control over how they do their jobs or the products they use. There's often limited computer skills or internet access, especially in more rural places in Vermont. IT support, if the a long-term care facility, for example, is owned by a parent company and that parent company is located out of state, they often don't have IT support on site. And the idea that there's not a one-size-fits-all solution, especially across facilities. It's hard to get everybody to implement or adopt the same new procedures. There are different cultures and approaches, certainly between acute and long-term care, but also across different long-term care or acute facilities. The long-term care facilities in some cases have really basic infection control needs. They have many fewer FTEs devoted to infection control, a lot less specific infection prevention training. And so, as I mentioned, the hospital IPs are a great resource for the long-term care facilities with regard to that. At times, the lack of engagement of their facilities administration has been a challenge. And so there are a lot of ways we've tried to reach out with them to administrators to encourage their engagement in this collaborative. And of course, the big ones that jump right to mind, limited personnel time and resources and turnover in staff. Again, especially in long-term care facilities, that seems to be a challenge. So how is the collaborative moving forward? We're continuing the cluster meetings. They happen locally, as I said. And what's happened is that there are a handful of long-term care facilities in Vermont who chose not to join the collaborative when we first started it. And some of those facilities are even now attending cluster meetings, even though they're not technically part of the collaborative. They're attending cluster meetings and they're using and implementing some of the things that the cluster is working on. So that's really great. And some clusters are going beyond the scope of what the HAI MDRO collaborative focuses on. So they're addressing other organisms that are not MDROs. They're involving other stakeholders like EMTs. And so those are really encouraging signs that this collaborative work is appreciated and understood, the importance of it, and that it's going to be sustainable because more and more people are being brought into the work. And then we'll continue pursuing our electronic data transmission to NHSN. We'll get those remaining hospitals able to transmit data. And as soon as the long-term care component in NHSN is ready, we'll get those long-term care facilities sending their data too. The clusters and facilities will keep implementing their interventions, keep trying additional ones. As I said, we're planning more learning sessions. We're hoping to be able to continue supporting the HAI prevention coordinator position at the health department to be a resource to facilities around the state. We're talking with the QIO, the Quality Improvement Organization for Vermont, to get their support both perhaps financially or with their staff time. They do a lot of work in healthcare facilities in Vermont already, so we're partnering with them to use our resources most efficiently. And then we're excited about planning 2 sessions this fall for residential care home staff to train them in basic infection prevention. So these are just things we're working on now. There's potentially lots of new projects in the future as we move forward. I wanted to mention this. I think it's sort of a byproduct of the collaborative and the great work that Vermont infection preventionists have been doing before this project started. The Vermont Infection Control Professionals Association invited long-term care infection preventionists to join their group recently. And they had their first meeting as a joint acute long-term care IP group in April of this year. And in September of this year, that larger joint group from Vermont is going to have a meeting with their counterparts from New Hampshire. So again, demonstrating that the infection professionals are a resource for each other across types of facilities and even across state lines. And we've been asked to share what we're doing in Vermont in a variety of settings, and I think in many more ways to come in the future as we continue this great work. We contributed to the CDC's Safe Healthcare blog. We presented at the 2010 CDC grantee meeting for the ERA funds recipients. We spoke on a CDC-hosted 50-state conference call about Vermont's MDRO collaborative, and we gave a presentation at this year's Council of State and Territorial Epidemiologists Conference about the collaborative. So thank you for your participation. We hope this is a good review. As new staff join your facility, please encourage them to take a look at this so they can get up to speed on what we've done so far. And hopefully in another year or so, we'll update this video with where we're at that time. Thanks.